Welcome, and thank you everyone for joining us today for our ALS Publication Review Series. My name is Jen DiMartino. I am the Executive Director of ALS ONE. If you are a first-time attendee, this initiative was launched about a year ago, really to connect the authors of important ALS research publications with the ALS community in an effort to help everyone really understand at every level, not just scientists, but everyone. And so we're honored to collaborate with NEALS on this. We work alongside of their information and education committee to bring you this. So today's publication review is going to be for the publication entitled Respiratory Strength Training in Amyotrophic Lateral Sclerosis, ALS, which was collaboratively written, and I'm going to list out all of the authors. So Emily Plowman, Lauren Gray, Jennifer Chapin, Amber Anderson, Terry Vasilopoulos, Clifton Gooch, Tuan Wu, and James Wymer. And we're really honored and grateful to have two of those esteemed authors here with us today. Dr. James Wymer and Dr. Emily Plowman. So Dr. Emily Plowman is a professor in the Department of Otolaryngology, head and neck surgery at Ohio State University, where she serves as the director of the OSU Wexner Medical Center Dysphagia and the director of the Aerodigestive Research Core Laboratory. Along with Dr. Plowman is Dr. James Wymer, who is a professor in division chief, as well as a Melvin Greer professor at the University of Florida Department of Neurology. I hope I got all of that right. We're really honored to have you both here. For our panelists, we have three people joining me here today. I'm grateful to have Gwen Petersen and Steve Kowalski, both of whom are just two incredible people, but they are also very powerful voices in the ALS community. They also serve as NEALS ALS Research Ambassadors. We are also lucky and grateful to have Dr. Bill Su with us. Dr. Su is an assistant professor, Department of Neurology at Penn State Health M.S. Hershey Medical Center. Dr. Su is also on the NEALS NICE committee. And we're really excited to delve into the article. So again, thank you all for being here. Doctors Wymer and Plowman, if you wouldn't mind just giving a top-line overview about the article, also, what inspired you to help collaborate on authoring it.
Yeah, well, first of all, on behalf of Jim and I, thanks for your interest in our work and for having us here. It's truly a great honor, and I'm really excited that we also have some pals on the call. But I guess to start off with, what inspired this collaborative team effort that was conducted at the University of Florida in conjunction with folks at the University of South Florida was that I really believe that individuals with ALS have historically sort of been overlooked when it comes to sort of active and proactive avenues for their care and for their symptom management. And if you look at the sports medicine literature and other sort of rehab areas and domains, there typically is a neuroplasticity and a window of opportunity where one can sort of target different muscles or systems to improve important functions. And as we all know, unfortunately, ALS is currently incurable, and the leading cause of death eventually is paralysis of the breathing and at times swallowing musculature that leads to respiratory insufficiency and in some cases aspiration pneumonia, but predominantly the former. And so we sort of had the thought that in early affected individuals with ALS, there perhaps could be a window of opportunity whereby if we sort of carefully applied a program of respiratory strength training that targeted the inspiratory muscles, which is very important for maintaining the function of breathing and specifically staving off the development of respiratory insufficiency, in addition to expiratory muscle strength training, which is very important for targeting the muscles that are involved with airway clearance capacity and being able to keep the lungs and the sort of breathing apparatus safe from material while you're swallowing going in there, or even secretion management. That perhaps if we applied this to early effective PALS, to see, first of all, was this feasible? And secondly, was this proactive approach, could this be an opportunity for, rather than sort of sitting there and waiting to react to a decline, and using device-assisted things like cough assist, or non-invasive ventilation, I should say, could this perhaps pump up the system and give it a bit of a boost, much like they do in other fields, such as patients undergoing surgery typically do sort of this prehab program to sort of hopefully improve their post-surgical outcomes. And so that was sort of the premise behind and the thought process behind our work. And Dr. Wymer, I'm not sure if you would like to add anything to that, just to sort of tackle that first part of that question, which was what was the inspiration for this?
Well, I would absolutely agree that a key part of this was empowering patients. That's what we really focused on, that every patient has an individual course, but as you go through this, there is this window that we believe we could provide some improvement. And when Dr. Plowman started this study, we looked for it as a way to just complement all of the other therapies. While we're trying to develop a cure for the disease, let's at least provide quality of life, improve function, try to redirect the course of the disease. And that was one of the major parts that excited me about it. The other is, there's been a lot of research out there about exercise and what can we do with exercise? What can we do? And all of the research, it simply says exercise is safe. There's very few ways to sort of validate, does exercise actually improve? And this provided an outlet where we could do a more structured study to look at a particular muscle group and see, can we actually improve? Now, this doesn't necessarily apply over to arms and legs, but the concept is still there, that with exercise in the right stages, can we provide improvement? And that was a lot of what we were looking for. I'll let Dr. Plowman go into how she structured it and what the study was set on. I think Gwen has a question.
Dr. Plowman, in your response, I'm hoping you can dive a bit more into kind of that window that you referenced early on in the diagnosis, and sort of, what you saw in that window. Thanks.
Yeah, and I'm happy. Thanks for that question, Gwen. I appreciate that. And I'm happy to answer that now. It might make a little more sense after we've gone through some of the results and a summary of some of our other work, but I'm happy to sort of give you a quick response to that. But, it's been quite controversial, and historically, the reason that it's been a more reactionary palliative approach to treating symptoms of ALS is the thought or the fear that, since this is a rapidly declining motor neuron disease, primarily, that there was this sort of fear that active interventions or exercises would actually exacerbate that motor neuron death and decline. And however, there's been some beautiful basic science work done in various genetic and sporadic ALS mouse models that early on showed that mild to moderate early intervention could actually prolong motor neuron life and the life of the rodents. Of course, this was an animal study, but that's actually the original literature that gave me the motivation to want to sort of do this and target really musculature that impacts survival. So this early work was done with mice that would run on treadmills or would swim in sort of modified swimming tanks, but you know, and which was great for their limb motor function. But as we just talked about, like the leading cause of death is when the respiratory muscles fail. And so that's why we thought this was particularly important for sort of staving off, hopefully, or attenuating the decline somewhat in that, or perhaps even just maintaining. But having said that, I say all that as a precursor for what I'm saying next is we do have to be careful. It's a very specific disease whereby you know, as opposed to maybe some other sort of rehab fields, we do have to be very careful with the amount of exercise that's being done, the dosage, as well as when it's being done throughout the disease progression. And we're still looking into this at this time, but we do believe that there is and some of this is based on some preliminary data. Some of this at this point in time, we're still hypothesizing, but we do believe, based on the knowledge we currently have, that the best chance we have would be getting patients who are early affected, meaning just recently diagnosed. And specific to this training, we've found throughout about 6 different clinical trials that patients that have a spinal onset or that their bulbar and respiratory impairment has not progressed too far along are the best candidates. And we just sort of believe at this point in time that if we're applying this to patients that unfortunately are too far progressed along, that actually it could be so difficult and taxing for them to do that any potential benefit is outweighed, unfortunately, by the fatigue and the amount of effort that would be required for these patients. And so it does sort of self-select in that when we've, across our studies, changed our inclusion and exclusion criteria. The one study we did where we lowered and were a bit more allowing patients with more progression to come in, a lot of those patients dropped out. And so we do think ideally, and this is still a work in progress to be very clear, but at least in my clinical practice, I really want to see a patient's forced vital capacity at 70% or greater to consider them a good candidate, or to even consider them as a candidate, to be honest with you, for this. And for sure, anything below 65% predicted in my clinical and research experience, I think, unfortunately, sort of that window where we could hopefully pump up the system a little bit has passed. And Jim, I don't know if you have anything to add to that.
No, I don't. But except to say that is why when you are diagnosed and seen by the neurologist, early evaluation by the speech and language pathologist, you may have perfectly normal speech. All of that may be good, but this is why the multidisciplinary care, that getting in to see the speech and language pathologist, because you can get interventions like this that can start before the disease to intervene on it. And that is a perfectly good explanation as to why you need to see them early.
Well, that's really helpful to have the backstory on that. I'm sure that there are a lot of people who haven't read it yet, but hopefully this will encourage them to do so. And I know that we have a lot of questions. And so Gwen, if you would like to go first and maybe give people some insight into your own personal ALS journey, if you wouldn't mind.
Sure. Yeah. I'm Gwen Petersen. I just passed 7 years since my ALS diagnosis, which is pretty extraordinary. I certainly know how fortunate I am. And the road to diagnosis was not an easy one. So back in 2017, 2018, it actually took 18 months for the actual diagnosis to come in. There was originally a misdiagnosis of anxiety, which was really hard to swallow. And I say that only because misdiagnosis and delayed time to diagnosis in general prolongs time to treatment and time to start these, critical interventional things. So Yeah, I take to heart, Jim, what you said about, being in an MDC and asking. Honestly, sometimes patients have to sort of ask the question. So, patients facilitating conversations with their neurologist, SLP, about these interventions. So thank you.
That's great. Gwen, I can only imagine that the anxiety that you were trying to avoid by getting a diagnosis just was causing more, and to not feel that you were being heard had to be very tough. So congratulations on year 7, and yeah. So you have a few questions. Did you want to go into those?
I do. Let's save my other questions. Actually, I'll let Steve go. My sort of question about the early window was one of my top. So Steve, let's take it away.
All right, thanks, Gwen, and thank you everybody for participating in this important work. I was diagnosed in 2017, so I'm coming up on 8 years this August. So I think the comment that ALS is a rapidly deteriorating disease, it is in some people, and then for some people it's a slow progression, and I fall under that category. I was diagnosed very quickly. I saw a neurologist here in Boston, and within 2 hours after having the 2 tests to look for signs of ALS were completed, I was diagnosed with ALS. So one may think that's a good thing. Actually, it was very traumatic because I didn't have the ability to ease into any diagnosis, let alone ALS. So it hit me hard and took me a good 90 days to just kind of figure this out mentally, how I was going to attack it. I'm very interested in the field of research when it comes to breathing, because as it's been said by Dr. Plowman, that ultimately is what most people, their life ends with their last breath as a result of living with ALS. So anything we can do to not only improve quality of life, but to understand perhaps when is the right time for intervention is critically important. So one of the questions, you want me to do my questions, Jen, or you want me to throw it back to Gwen? Questions, okay. One of my questions is, relates to sleep. There's been some research that an early indication of perhaps breathing difficulty happens while we're not conscious. We're actually sleeping, and it may be sleep apnea or anything like that. Was that at all considered in your designing of the trial, taking into an account of perhaps a sleep study?
I'll start with that, and then I'll let Dr. Wymer sort of chime in. But and it's great to see you again, Steve. I have fond memories of working with you. Gosh, I think it was 2 years ago for our NIH panel. So it's lovely to see you again. Thanks for joining. So in this particular trial, this was about, I believe, the 4th or 5th study we did in this area, and it was a higher level of evidence from our previous studies. We sort of course, started with some sort of proof of concept studies and some case studies, and then we sort of evolved into an open label small cohort study. And as you know, this was a sham-controlled randomized clinical trial with a sham group and a active group. But one of the early or primary aims was to determine, is this feasible, and can patients actually complete this without any adverse events, what we call AEs? And so that was primary number 1. Number 2 was, since we're directly targeting the expiratory and the inspiratory muscles. Our primary outcome treatment variable was maximum inspiratory pressure and maximum expiratory pressure, because that's directly sort of what we're targeting. And then we had these secondary outcomes, sort of related measurements related to swallowing, to cough and airway clearance capacity. And then finally, as an exploratory aim, we had 12-month follow-up outcomes, which actually I'd be excited to talk about at some point in this podcast recording, given that, sometimes when you publish papers, everything comes down to the statistics and something being statistically significant. However, I would argue sometimes the devil's in the details, and what is clinically meaningful to a patient may not actually evolve or show on a statistical test. And so at some point, I hope we can talk about that, because we did have some exciting clinically meaningful findings related to the ability to maintain eating without a feeding tube and also breathing without non-invasive ventilation at that 12-month mark. But to sort of get back to your specific question about, it's a great question, it's a great thought, but that I think that we could further explore later on, and maybe we'll need to collaborate and chat with you and get your input. But in these early studies, we're really sort of focused more primarily on sort of what we call a homogeneous as possible group, because that's important from a research design standpoint. And so our inclusion criteria was that individuals had to have a forced vital capacity that was greater than 70% predicted. So we didn't want patients who were too far along for this early work because of the historical mandate or fear that intervening could actually make folks worse. So we wanted to see, in these early affected, still relatively preserved patients from a respiratory breathing standpoint. And as well, their ALS functional rating scale revised needed to be 34 points or higher for the same reasons. We did not take into account presence of sleep apnea. And it's a very thoughtful and intuitive question, because this type of treatment has been used separately for folks that do have sleep apnea. So you're really onto something there, Steve. And Dr. Wymer, I don't know if you have anything to add to that.
Actually, you just did a beautiful job of where I was going to place it, because sleep disordered breathing is a huge problem, and it can start very, very early in the course of the disease, and it may go unnoticed by the patients, but it may be there clinically. And this again gets us back to the point that we said about the importance of early evaluations, early interventions. I'm not saying every patient needs to get a sleep study to look for this, but certainly every patient needs to be evaluated with the history to see if there are those things, because if we can intervene early, we can introduce these types of interventions that can have implications throughout the course of the disease.
Yeah. Steve,
Yeah.
I think that you're on mute. Were you?
Sorry
There you go.
about that. Do you want me to go with another question, or do you want
Yeah,
to?
that would be great. You can.
So in the paper I've read, there was a clear need to examine RST in larger cohorts moving forward if you were to, continue with another study. Would you change any of the inclusion or exclusion criteria to get to a larger cohort, or would you simply be looking for more people that currently fit the inclusion exclusion criteria you currently have?
Yeah, so I think obviously to be able to generalize findings and what we sort of refer to as the external validity of this work, we can't necessarily assume that these findings are 100% representative of every individual with ALS. There could be a number of reasons for that. So that's why we do need to sort of replicate these initial findings in larger cohorts. And the next step would be to likely move into more heterogeneous patient populations. If I could go back and do this study again, which is sometimes keeps you up at night,
Yeah.
but I really kicked myself afterwards, because we historically had only done expiratory muscle strength training, and we did this these are one-way spring loaded calibrated valves, essentially, that someone for expiratory breathes out into, and must like I said, it's a one-way pressure valve, must kind of break a threshold or a seal to perform reps. And so we can load that at a relative percentage of a patient's 1 rep max, if you think of a bench press. And this takes into account a lot of sports medicine principles of muscle loading to gain, strength. And historically in ALS, we have used a 50% 1 rep max load. And because we were expanding this to include both expiratory and inspiratory muscle strength training, and essentially doubling our daily repetitions, we were very cognizant that we did not want to do any harm and overload these patients. And so we dropped our load down to 30%. And I know from doing subsequent work and just comparing the relative change in patients that load is really important, and it kind of makes sense, right? If anyone here has a strength training background, and 30%, I don't believe, was the optimal dose. And actually, we should have been higher at 50%. So I would absolutely change the dose, which wasn't quite your question, but that's the biggest thing that I would absolutely change. But I would tend to, at least in the initial replication of this work in a larger cohort and across different geographical regions would be important. I would want to keep at this point the inclusion criteria in general still to the early affected patients with a forced vital capacity greater than 70%. I can also say anecdotally in my clinical experience, I've seen hundreds of patients or patients that have come to see me specifically for this. And very consistently, anyone whose forced vital capacity is lower than 65%, it is difficult for them to perform these exercises. And so I feel pretty confident that there is this window. The question is exactly what is it and where is it at?
Well, you answered my final question somewhat, but I'll say it anyway to see if there's anything else you want to add. But to live with ALS and to be involved in the clinical trial space, you really need to remain optimistic, right? Because we've had just a lot of fails over, decades, and certainly during my diagnosis as well. But I don't believe in a failed trial. I always believe that there is something we can learn from any trial that maybe didn't meet its primary endpoints, but we can learn for what we could do moving forward to better our understanding and design a trial that may get us to where we need to be. So in general, it's just an optimistic view of what you've learned and what you would recommend anyone think about if they were to think about studying this area moving forward.
Mm-hmm. Sorry, Steve, I just want to make sure I exactly get the question. Would it be the take-home points of the trial?
Yeah, exactly.
Yeah. So I do think, we didn't really talk about a summary of the results, but just to quickly, I think, summarize those. We did have mixed results, so not everything improved, but specifically one of the two primary outcomes, maximum expiratory pressure, was significantly improved in PALs that were randomized or assigned randomly to the active group. And then some of the cough or airway clearance metrics were as well. But what I thought and what I would encourage future investigators to do, we did include that exploratory aim that I've alluded to, where a year later, we compared both groups of individuals. And as I sort of mentioned earlier, although statistically there was only one long-term follow-up variable that was significant, and specifically that was the ALS FRSR bulbar subscale slope. And when we refer to slope, that's sort of the delta or the change over time. And essentially the decline in the bulbar subscale score was attenuated approximately threefold in the folks that were, it was slower in the folks that were assigned to the active group. So that was very interesting. But the two outcomes that I wanted to talk about that I think future researchers could maybe think about looking at further, I think we were underpowered for this. But when we looked at the number of patients who were what we call nil per oral, unable to eat by mouth, versus those who were consuming an oral diet, all of the participants in our study were on a full oral diet, or some form of an oral diet, I should say, at the commencement of our study. And a year and 3 months after the study, it would be 87% of individuals in the active group were still eating by mouth versus 64% in the sham group. And although that wasn't statistically significant, I can guarantee you it was very clinically significant and meaningful for those individuals who were still able to eat by mouth. And the other one that was even more exciting was the time to non-invasive ventilation. And on average, those in the active group waited 12 months longer compared to those in the sham group from their time from diagnosis. So it was a 12-month delay in time to non-invasive ventilation. And again, that wasn't actually statistically significant, to be very clear. But I would argue that is a very meaningful difference for a patient and their caregivers and families to their quality of life and symptom management. So I would really encourage other investigators that may be interested in this to think about some of these more functional long-term outcomes versus sometimes just the direct things that we're working on. And I would also, it's a perfect place to bring this up because, you know, like you're here as well as Gwen and some others, but to also reach out to PALS and to their caregivers and really include them in the research design and what is meaningful. Because one thing we were able to do for this study, because it was funded, is have therapists go out on a weekly basis to patients to work with them in doing the therapy, retest and recalibrate the trainers. In our first study, we weren't able to do that, and we had a drop rate that was much, much higher because it just wasn't feasible for PALS to come in, and some of the, you know, some folks live quite a fair distance because it's just too much. And that is something that has to be carefully weighed up. What is the amount of sort of time and energy expenditure for a patient and their family on what are the potential gains? So, so that those would be probably some things I would say just to think about for future studies. Yeah.
Great, thank you.
Really, just really important information. And also to, I think it really highlights the importance of these non-invasive studies. And, you know, if you're in a study, obviously, that involves, you know, medication, and you don't see efficacy and the trial goes away, you're not able to, you know, benefit from the secondary endpoints, perhaps because it's gone. But for this study is a perfect example of how you can continue to possibly receive those benefits, and it's really extraordinary. So
yeah, and Jennifer, I would add, if I may, as well, the nice thing is that this is very scalable and accessible for patients, and that the sorry, I have dogs that are jumping up.
yeah, no.
They agree. In that these devices on average cost about $50. They can be even ordered online, but I would highly encourage and recommend that one must work with a trained therapist to get started with these. But having said that, they're inexpensive, they're portable, accessible to my knowledge, to almost everybody. And they can be done in the comfort of one's home once that someone has been sort of trained in the methods. We've also, by virtue of needing to during COVID, developed telemedicine techniques for doing this as well. It's better when it is in person, but there are ways to do that remotely as well. And so I think that's really exciting as well. And you're right, Jennifer, that like these sort of either non-surgical, non-pharmacologic, they're not sometimes considered as sexy or as important, or they don't get as much perhaps funding or attention. But I think from a symptom management standpoint, and even, you know, I love working with PALS because they kind of really do teach you about, you know, the human spirit needs a sense of hope. And Steve mentioned that earlier, and a sense of purpose, and never to misuse that, because to be clear, this is not curative. This is an behavioral exercise program that we hope can help with symptom management and pump up the system and push off or down the road certain, you know, events. But, you know, it does give patients as well, I've found anecdotally, consistently, that a bit of a sense of hope, but a sense of purpose as well. And I think the human spirit really benefits from that as well. And I guess that's a bit more on the softer side or fuzzy side, but you just said something that made me think about it, as did Steve earlier. So I think, you know, that's important too. And I think Dr. Wymer can attest to that, and he's seen a lot of this too.
Absolutely. Hope is what we try to bring when you come in to see any one of us. And it's hope, it's empowering the patients, it's developing a care plan specific for them. This is what seeing in a multidisciplinary clinic, whether it's at Penn State and Ohio State or Florida, we are all focused on the same thing, and that's empowering the patient.
It's so wonderful to hear, and I think it definitely underscores the importance of those, multidisciplinary clinics wherever you are. And if you're not near a hub or one yourself, how do we ensure that, all people have the ability to participate in things like this and really to feel a part of it and to feel heard and seen in this way, because this is so important. And this has been really great to delve into. So thank you. Dr. Su is with us, and he is assistant professor of neurology at Penn State Health. And welcome, Dr. Su. We're so happy to have you on the panel. And maybe you could give a little bit of your history and what really got you into not only neurology, but ALS as well.
So I have to apologize. I'm not sure if you can hear the background noise. I escaped the office because there was construction, and now there's construction outside my house. So it's interfering with what I can hear.
It. We can't hear it.
Good, excellent. So yeah, so I actually did my PhD in ALS research at Penn State. And after leaving for residency, when I got the chance to go back, I chose to return to Penn State because we have a very significant focus on research and clinical care that focuses on the quality of life of the patients. And more recently, we've entered into collaborations that look specifically at respiratory both assessment, whether there are better ways of assessing respiratory function. We're looking at hypoventilation, looking at carbon dioxide monitoring and non-invasively, as well as different methods of stratifying and potentially improving respiratory drive. So I was very, very excited to be able to discuss the research today. I had a couple of questions prepared, but many of them have been partially at least addressed. So I'm going to actually go with the last question I had prepared, which is, if you are someone with ALS or a researcher interested in ALS, what would you suggest as the best next step? Based on what is known so far, what can someone do to improve their respiratory function or slow the decline? If you're interested in collaborating even or doing your own research on this type of behavioral change, what is the best way of starting?
Yeah, so I'll start, and then I'd like my partner in crime, Dr. Wymer, to sort of add his thoughts, particularly from a neurologist standpoint. But I guess I'll sort of start, and it's a great question and great to sort of virtually meet you here. But when we first started doing this over a decade ago, it was not popular or very well received, I'll be honest, because of that historical mandate and sort of thought that we don't actively intervene, and there's this more palliative reactionary care. And so it's been great to see this sort of evolve over time. And I think the proof of concept has at this point come out. And so now the devil really is in the details regarding, well, what is the right dose in terms of what is the right loading of the muscles. We do load quite a bit lower, even at the 50% of someone's 1 rep max, compared to traditional sports medicine loading principles, whereby there'd be a progression typically starting at 60% and going all the way up sometimes to 80 or 85% of someone's 1 rep max. And in other populations, such as Parkinson's disease, they do that. And for reasons that I've previously mentioned, we're much more conservative in ALS. And that's a very important point, because sometimes when people hear about doing exercise, they sort of are like, whoa, that's, you shouldn't be doing that. And so that's an important point. But for future studies and for future researchers, we still, I think like any good study, this study had more questions than answers at the end that now need to be responded to or dived into to sort of test. But looking at optimal dosage, optimal time points, and I do think, as I mentioned earlier, the 30% load used in this study, I think it wasn't optimal, and we under sort of utilized that. And so for future studies, I would be pushing for 50%. It could be possible that we could even move and get better results, up to 60%. I'm not sure. Other work that we had started doing, and one of my former doctoral students, Dr. Lauren Tabor-Gray, is now doing a study looking at breath stacking or a combination of breath stacking techniques with respiratory strength training. And I think the beauty in that is you're actually combining the respiratory strength training used in this. This is a load-bearing strength exercise, but as we all know, breathing is more of an endurance thing, and we don't actually need maximum strength to breathe efficiently every day. And so this was sort of targeting airway clearance muscles. But with breath stacking, for most of those who are probably familiar with it, but if you're not, this is more of an exercise rather than using a load. We're actually using range of motion to sort of actually expand. And so I think ideally a combination of a load or a strength based program with a breath stacking that's not targeting the pressure generation, but more of the volume of air that one can breathe in or out could be potentially synergistic and ideal. And then the last thought I'll add to that is we have serendipitously observed that a combination of pharmacologic interventions with behavioral can have some pretty outstanding results. And specifically in one of our earlier trials, unbeknownst to us, one of our patients who we track data on every week started Dept, and their data just went off the charts when they added Dept to their exercise regimen. So I think perhaps a synergistic combination of pharmacologic interventions in the right patients with exercise could be really great. And we have published also data just specifically looking at Dept with bulbar function that Dr. Lauren Tabor-Gray was a co-primary investigator on, the first author that was recently published. So I do think that there's emerging data, and it's a really exciting time, but more work is needed to be done on those details. And I don't know, Dr. Wymer, what you would add to that.
Yeah, I want to add one particular point that you're probably not going to mention, but is absolutely critical to the success of this for the junior person. It is okay to think outside the box. Okay, exercise is harmful. Exercise is terrible. We can't do it. When we got into this is what everybody was saying. This is what all of our collaborators, they were encouraging against this. Well, there is all this science that says the right exercise is good. So being able to ignore what people are thinking, to look outside the box for those junior researchers, if those researchers are looking to get into this and they have an idea that they think could potentially work, do your background, look at your animal models, look at the data, ignore the dogmatism that's out there that you can't do this. Okay, and by doing that, that's one of the great points about this entire whole course that Dr. Plowman has gone through. It has taken something that said that we can't do this. There's no way we can do it. And not only has she shown we can do it, but she's shown that it can actually help patients, empower patients, and lead to success.
It's Dr. Plowman, Dr. Wymer. So I have been a patient at 3 different clinics, all MDCs. And unfortunately, this study, the benefits of this study has never been discussed with me as a patient. I can only imagine for folks who are not at multidisciplinary clinics, they're not getting this information. So a couple things there, hoping you can sort of help me. How do we empower our SLPs to at least give us the information, show us this study, the results of this study, and then a lot of times I mentioned earlier, patients have to ask the right questions. So if our specialists in clinic aren't giving us the information, how do we empower patients to ask the right questions?
Yeah, I think that is an extremely important question. And as Dr. Wymer did mention, this has been sort of a body of work throughout my career. I've been working on this personally probably for about 18 years. And sort of the first 5 years, everyone thought I was crazy. But the data speak for itself over time. And we weren't sure how it would turn out, but we at least wanted to try it because unfortunately that dogma wasn't really based, if you looked very carefully at the bulbar literature, on any evidence whatsoever. And so we wanted to at least try. And fortunately, the data have shown that actually in the caveats, again, the devil's always in the details, but with the right specifications, this potentially could be quite beneficial for symptom management. But I do still hear exactly what you just mentioned, Gwen, that there's still some resistance because this has been a historical sort of dogma, and Dr. Wymer can probably speak more knowledgeably to that as a certified neurologist who's worked in the field for a long time. But I will say it's interesting, and I was just talking about this on the weekend, but just this month I've been asked to do 3 different webinars or panels related to this specific article. But the sad thing about science is it's so slow. We did this study, gosh, what was it, Jim? Like 8 years ago, and it took us several years to collect all the data and do all the 1-year follow-up. And then it was very difficult to get it published. In fact, I will tell you that this got rejected from Neurology. And I've never done it ever in my entire life. And I was talking about this earlier in the lab. But we respectfully wrote back to the editor because of one of the reviewers' thoughts on it. And they sent it back out for review. And then not only was it published, but it was featured as the featured article on their podcast. And so the road isn't always straight or easy. And so thank you, Jim, for mentioning, that earlier. But I think it is important to be honest and transparent and vulnerable with that it hasn't been an easy, like clear-cut road at all. And so there is some resistance when you're doing things a little bit differently. But I think if you always hold the ground truth, and the North Star is always the data, and the data aren't clean either, right? Like not everything improved on this. But I think that feeds back to, though, what you're saying, in that it's not something that we're kind of, I guess, swimming upstream a bit. And this is going against, decades and decades of a specific mandate or thought. And for particularly some of the more senior and influential clinicians, they weren't raised, so to speak, academically or in the medical field to think that this could be something that one could do. And so I think it's a big paradigm shift. And I don't blame folks for being a little bit resistant or saying, okay, you need to sort of prove it to me or show it to me. But this was completed quite some time ago and published several years ago, but it's only now sort of, it's now getting traction where people are sort of asking about it. And in my most recent podcast, I was asked, I won't say where, but I was asked to do it. But then they also suggested that I had someone debate against me for why it wouldn't be beneficial and if I'd be open to that. And I thought that was really, really quite interesting. So I think that's what you're experiencing. And I don't know if both of the neurologists on the call may want to, Dr. Su and Dr. Wymer, probably have a better insight than me, to be honest with you, or to at least add to that from a neurologist standpoint.
So one of the most memorable talks I heard was from someone, a senior neurologist, who had mentioned that when he was young, if he thought that if people continued to do research that the way that it had always been done, that we would have smaller, portable, possibly more sophisticated iron lungs, but we would never have the eradication of polio that we do now. And that essentially what we're doing is making changes and working towards, well, right now we have ways of supporting ALS, but eventually we want ALS to go the way of polio. But then he made a very important point. He said, well, on that road, we're investing all of these resources towards that cure. But if you look at malaria, the amount of money that's been spent towards understanding the basic research and curing it, compared to the amount of money that it probably took to invent the pesticide and insecticide coated the mosquito net is drastically different. And if you just think about how much of an impact that had, there's these things that are low-hanging fruit that you can really target and benefit people. So I think it's really essential. And this is a study that kind of points to both of those sides that he pointed out. And I think the point that Dr. Plowman made of what types of things that we can target for these individuals. As neurologists in clinic, we measure many different parameters. The things that the physical therapists often look at, they look at things like strength and muscle atrophy and muscle cramps, but they also look at range of motion and spasticity. And I think from a breathing standpoint, one thing as neurologists and as speech language pathologists, as pulmonologists, we look at, yes, the strength of the diaphragm, the strength of the ability to breathe and to exhale is important. But ALS also has the upper motor neuron component as well. The compliance of the system, how much the musculature is able to constrict and to relax, that is also essential. I also actually wanted to ask, from the different parameters that you were targeting in the study, what do you think are some of the most important parameters to measure and also to target for improvement?
Yeah, wow, that's a great question. It's a little bit loaded in the sense that one thing I would my blink on response to that is what is functionally meaningful to the patient, and that is going to be personalized and likely a little bit different. And this is definitely what when I worked with Steve and some other amazing pals on an NIH panel a few years ago. I think actually it was Steve that said this, and it kind of blew my mind. And it's so simple, but just asking a patient, well, what is most meaningful to you in your life to improve? Because at the end of the day, that's the thing that matters most, right? So, however, it's a little tough to do that because, as you know, with clinical trials and research, you do have to standardize things. But I would like to start with that, and I still haven't figured out in a sort of elegant way how to, exactly incorporate that. However, I would say at the end of the day, the functional things that really matter, the time to non-invasive ventilation, the time to prolonging the amount of time that one can eat safely by mouth, or preventing the need to rely on a feeding tube. All those functional metrics to me are at the essence like the most important things, but it does take other physiologic targeted things and the way we measure them to sort of typically get to that. And without going too much too academic and too into the weeds on that is why we did target the expiratory muscles for airway clearance and for preventing or helping with secretion management, or if aspiration did occur during swallowing, to be able to adequately defend the airway and allow folks to eat safely, as well as with on the inspiratory side, working on staving off respiratory insufficiency. And so I know in most clinical trials, the ALS functional rating scale and forced vital capacity are typically the top, sort of markers. But at least for the work that, we do, our sort of most, I guess, physiologic important metrics are ones related to airway clearance and being able to protect the airway. And then these functional metrics of being able to breathe on one's own and being able to eat by mouth. But I would love for Steve, if he is open to it, to add on to this, because it was Steve that really kind of changed my view as a clinician and a researcher. So Steve, I don't know if you remember that moment when we were, but I do.
We were talking about the ALS FRS scale and how it appears to me that conclusions are drawn from that about your quality of life.
Yeah.
And so I took exception to that because those measurements, although they're important in a scale and it's needed to measure progression, you can't make the assumptions based on someone's quality of life without asking them quality of life questions. So that's really how that conversation started. And I hope it made its way into our recommendations to the NIH, because I think it's critically important to look at that that aspect as well.
Thanks, Sue. Yeah.
And I will say, since that time, quality of life scales are very much included in almost every study we do. So I think it did.
Good, because that's good news.
Well, has been really great. I know we're just almost out of time. In case anybody has any final thoughts, I think one thing I'm really happy about is not only do we have this initiative to help the ALS community, but also to amplify this really important work. So I feel badly that this was published, 2 years ago, I think April of 2023. And I think about, all the people who probably would have loved to have known about this, as Gwen and Steve said. So, we will do our part going forward to make sure that they are aware. But before we leave, are there any takeaways that haven't been mentioned by you, Doctors Wyman and Plowman, that you would like for the audience to take away from when they do read, or if they have already?
I think I've been able to sort of mention everything that was important to me, but I would just say folks can reach out to me if they need any further information. I'm now at the Ohio State University in Columbus, Ohio, but still communicate and text with Dr. Wymer, and we have another study that we're still involved with, but I'm also happy for speech language pathologists to reach out to me. And we are trying to do some grassroots educational efforts, but it does, I think, take time. So unfortunately.
Yeah, well, we're here to help in any way we can too, to help spread the word. And, I know our research ambassadors would love to help too as well. So, and Dr. Sue. So, thank you all so very much. Dr. Wymer, any follow-up final words from Dr. Plowman, or pretty much?
Ask questions.
Yep.
Ask questions. You come up with ideas. Patients who are living with it, you can come up with things that can push our knowledge. We are here we learn as much from you as we learn from the science. So please, you identify things, ask questions, ask us. And
Perfect.
go Gators.
Go Bucks. We won the national championship. Well, actually, you did too. We both did.
Oh, well, thank you, everyone. Thank you so much. And thanks to everyone who has tuned in as well. Really grateful for everyone. Have a great rest of the day.
Thanks, Jennifer. Thanks, guys.